Пока филд ашпай тұра тұрмыз. Все, спасибо. Hello, dear colleagues. Гидрофильм алып тастайсың. Сәлеметсіздер ма? Ассаламу алейкум. Здравствуйте. Bonjour. Guten Morgen. Buongiorno. Қандайсыздар олар? Нихау, конничуа. Merhaba. Hello, dear colleagues. My name is Mynzhylky Berdikhojayev, and together with my assistant Rawan Maratlaiteli, we are from Presidential National Hospital in Almaty City, Kazakhstan country. And the operating nurse is Bakht, with the second nurse Akhil. Anesthesiologist today is Dimash, like Dimash Khudaybergen. He's a very famous worldwide pop singer, Dimash Khudaybergen. And the anesthesiologist is just Dimash. With the anesthesiology nurse Naila. And video support today presented by Roman Povyshev. Roman is a member of the Videon company. The owner and creator of Videon company is Evgeny Grishayev. He is today he is busy. The air conditioner is broken. That's why he should fix it. In Almaty now is very hot. It's approximately 40 degrees plus. It's a Celsius. It's not Fahrenheit. I think in many places like this, at this period of time, it's very hot. And I have been to Tashkent a couple days ago, and it was 47 in the, not at the sun, at the shadow. It was 47 Celsius. And in some places in Kazakhstan, it's possible to fry the eggs with the sun energy. Yes. It's not only the chicken eggs. If you put your eggs on the asphalt, you can fry it. It's just kidding. I'm joking. Yes. Today we have a patient for the second session. The first session was done in March. This year in March, and we worked through the Paika territory. And now we have this picture. It's a cast of previous embolic agent through the, I think it was a Paika. And yes, it's Paika territory. And AVM is still alive. The half of the AVM is alive, and now it has supply from SCA, from ICA, from Paika on the left side, and on the right side Paika supplying the AVM. And then the right carotid territory is intact. It's not supplying the AVM. It's algorithm. We should check all territory, including the extracranial carotid, external carotid artery territory. And on the left side, the ICA territory is clear. And the ECA territory, extracranial circulation territory, presented with the collaterals, with the feeding branches to the AVM from the middle meningeal, and might be posterior auricular artery is also going to the territory of the AVM. small tiny feeders, which is very important when you attack the AVM. It might be some supply from the posterior meningeal, and this territory could be a little bit risky because of the cranial nerve supply. The left vertebral artery shows the dominant ICA feeding the AVM. Main fistula should be here, but it's quite close to the brain stem, but I think it's a little bit far from brain stem because after this curve it's mostly cerebellum, and it's on the hemisphere on the left side. This is a pica going, it's mostly the brain. SCA is duplicated, the 1 and 2nd. We should check the SCA also. I prefer to, and I hope Rowan will agree with me, to go through the smaller branches to take part of the AVM, and the main part of the AVM we will leave for the third session, might be in combination with the transvenous. Yes, it should be nice. Yes, just a moment with it. Yes, it was not ruptured. It's not ruptured AVM, but I think the chance of rupture in this young lady, just 21 years old, posterior fossa with this stagnation, it looks like venous aneurysm. Yes, it's a venous aneurysm. Yes. It's a question of time when this AVM will bleed. That's why it's a clear indication for the treatment. I'm not sure from the beginning it was the candidate for the gamma knife. We can measure. It should be single draining vein, and no, it might be candidate, but it's close to the brainstem. Maybe we should discuss with the team of gamma knife radiosurgery in Astana. The only point, if we will send this patient to Astana, then there are also endovascular team, and they can do some kind of treatment. But if it's possible to exclude endovascular, might be it's a better approach. We'll see. We will see. There another branch, more perforating. Okay, let's see. Now the short cheese, Turmo radiofocus, 11 centimeter 8 French, and then we have the last neuron max catheter for the patient coming through the quotation. Yes, it's the last neuron max, and then we have two destination catheters, which is quite stiff for the vertebral territory. Two Y connectors from Balt, and we asked for the sonic 1.225, and then we have another 3 sonic 1.525 for the whole treatment. It's available material for the July. This time the situation looks like this, and we're limited from sources, and we should very accurately occlude part of the AVM. The goal of the treatment is not total occlusion. We have no so much microcatheters, and if we will start to occlude the vein, then we should finish the game, and we have no enough material for this. It's more than 1, 2, 3, 4, 5 feeders, more than 5 feeders. That's why I need another couple of microcatheters. Okay, let's do it in a stage which manner? Stage embolization. Okay. I will take this. This. Yes, nowadays my colleague Maksat is doing cases on working days, and I prefer to come, if it's possible, on weekends to exclude the quay into the operating room. Yes. Nowadays it's look like this. Yes. Maksat is very experienced student of mine. He came to the vascular neurosurgery department in Astana in 2012. He was my resident for 2 years, and I tried to teach him for the all tips and tricks, and nowadays he's a teacher. He's teaching young physician. Вперед. Вперед. Стоп, назад. Smart mask. Okay. I prefer to check the pica, and then we will go to the SCA territory. Also, we have supply from the meningeal artery on the right side. On the left side, yes, sorry. The left meningeal is also supplying. And now the sonic, which come with the hybrid 7 in the box. Yes, on AP it's look like we are inside. On lateral it's look like we are inside. On AP it's look like we are quite distal from the branches. Yes, the brain AVM, I think it's one of the most complex disease in the cerebrovascular pathology. Yes, the part of the AVM is feeding from here. It's an passant feeder. It's quite okay. I think it's en passant, and there are bifurcation, and then it goes to the AVM. This branch goes medially and crossing the midline, but it might be collateral. It looks like it's collateral. Okay, let's try to push it a little bit forward. Okay, now we are inside the branch. Yeah, it's nice. Nice one. There are bifurcation. Now we are at the point of bifurcation. One branch goes to the cerebellum hemisphere, and the second one goes to the AVM. Yes, this branch is going to the AVM. Yes, this one goes to the AVM. I think this is quite safe branch, and we can work from here. Yes, it should be okay. It's a quite posterior part, and it's distal from the brainstem. Okay, let's take the wire. And I will ask Bachat to give one Sonic 1.5 35 25 1.5 25. Тағы бір Sonic бере салшы, Бахат. Yes, Sonic. This I learned from René. If you need to do, René is Professor René Chapeau from Germany. It's a very typical German name. Chapeau, last name Chapeau. Chapeau is very popular in Germany. sorry, René. It's a truly French name. But René is working in Essen. Essen is a poor German city. It's 50 kilometers from Düsseldorf. It's western Germany, close to Dortmund and Köln. Yes, I visited first time Essen in 2012, and I love to visit Essen. It's one of my favorite places to go. And this year in November 11, 13, Professor Chapeau is organizing the Ellis course number 11. I think it's number 11 because before it was edition number 10 and okay, it was edition number 10 and now it's edition, I think it will be edition number 11. Yeah. Yes, for the Sonic it's very important to push the microcatheter in a tortuosity if you have the wire inside, and it's more safer. Okay, there are small angulation at this point. Distally a little bit tortuosity might be. Okay. Okay, now it's going. Okay, it's coming. Yes, it should go. The important point, we shouldn't take the wire proximal to the second marker. Okay, I think it's okay. I think we are quite distal enough. And with this branch, the main principle is to create the plaque before the second marker, if it's possible. And I hope there is no extravasation. I will pull it a little bit to relax the microcatheter a little bit. I hope it's not detached. Sometimes it might detach. Okay, it's a small feeder. Yes, the chance of rupture is very high, but the feeder is quite small. Maybe I need to pull back a little bit. The feeder is too small. Okay, let's leave it like this. we can inject from here as much as possible. Okay, let's leave this microcatheter here, and now we can take Sonic 1.525. Так, алдында гибрид болмайды, новый керек. We need a new hybrid because the previous one is no Berdikhojayev. It was a hybrid James Bond, and now yes, the Alice meeting will be November 11-13. I hope to attend, and I hope my father is still in the hospital in Astana presidential, and he start to recover, and now he is better. He had a stroke 24th of June, and June 7 we bring him to the Astana presidential, and together with colleagues we discussed, and he had a pneumonia. That's why we placed him, hospitalized him to the department of pulmonology. And he's doing well. He has fever once a day, 37-38 degrees, but it's usual scenario after brainstem stroke, and but he has no paralysis. He's moving all 4 extremities, but slight dysphagia is in place. Okay. I hope my father will recover well, and I can attend the Alice meeting. I hope so. Topographically, it's a territory of SCA, but we will place the previous angio. This one. It's a beauty of smart mask. It's 100% video. This one is for the SCA. Yes, I take the microcatheter a little bit back, change the angulation, and push it forward. It's all the time 2 hands work. Okay, let's do the angio from here. Yes, that's a nice feeder. Один ворот. It's a nice feeder to the AVM. It's quite distal. Okay, let's check the upper one. There another branch, another SCA. Так, верхний мышечка выбрал. Okay, let's go to this. Okay. As the Vietnam meeting in Kanto finishing today. Yes, I should attend this meeting in Kanto, but I couldn't because of this force majeure in my life, and many warm feedbacks from friends, they really enjoyed the stay in Kanto. And Professor Chapeau said he's traveling today from Kanto to Germany. Yes, that's really nice. Professor Kwon is organized very nice department and the comprehensive teaching center for stroke. I think it's upper branch. Yes, it looks like it's up. It looks like there are another one, but it's right side. Okay. Let's check the laundry. It's quite hot in the operating room. The air conditioner 17, and yes, Evgeny also had the problem with the air conditioner in the. It's quite small branch, but it's there. Stop. Вперед. Вперед, 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 вперед. Назад. Вперед. Yes, this branch is going to the AVM, but I think the previous one was bigger, huh? Bak altından sıkışmış. Bakın diyeyim. I think this one is bigger. It's quite bigger. Okay, bondings. Stop. Назад. Stop. Smart mask research. Okay, maybe we'll catheterize this branch. Okay. Общий ангиографин смарт маск повесил. Пока общий повесил. Cheers. Yes, the upper superior cerebellar artery is giving mostly the supply for the vermis. That's why it could be a little bit dangerous, huh? The vermin territory. But this branch looks better. Okay. I think and суперселективно предыдущий. Blendings. Ага, все, смарт-маск. I think we should go somewhere here. But then it's doing like most because okay, just a second. I think it's giving the U-turn. Yes, it's giving the U-turn like here. The both branches are going to the AVM. Okay, let's see. Do a branch like this and okay, let's do Andrew. It's a very small branch, tiny. Ну-ка, ну-ка, вперед. Oh, okay. It comes somewhere here. Here is a bifurcation. As that branch smart mask. Okay. Yes, sometimes the small branch giving more opportunity to occlude the most of the part of the AVM. And also the Venus approach is giving more opportunities to cure completely the AVM. But for the Venus approach we need a coiling catheter, we need it's better to have also the NBCA, which is not available in the country. Okay, we don't need to go to the smaller one. We need to do U-turn. I think it came a little bit earlier. Is it this one? It might be. Okay, let's try. No, it's not this one. It's another small one. You should come a little bit earlier. Goes more proximal. Goes more proximal. Okay, maybe we can take the micro a little bit back. And this one, it should be more proximal. Okay. Let's do the angulation for the micro wire. Yes, for this reason maybe we need something stiffer. Something stiffer like a Chikai 8, Chikai 10. Not the hybrid. Hybrid is quite softer. Okay. There are angulation, but it's not like this. Yes, nowadays the financial support for the endovascular cases is going worse and worse. That's why many hospitals are changing the approach. They're doing less embolization and more and more microsurgery to save the money. Yeah? But in many cases endovascular option is the main option. Okay, and after that the some part, okay, this one. The some part of the patients became non-treatable. Okay, now like this. We should go with the microcatheter. That's a real U-turn. Huh? It's sticking somewhere. Okay. Going to the small branch. Okay. Let's come. It's a little bit deformed. Maybe now it's better. Maybe after doing this U-turn we should go hybrid 7. Okay. Okay, now it's going the right way. It's going to the PCA territory. Yes, there is no support. That's why it goes like this. Okay, let's check the angio. There are too many manipulation, and I hope everything is clear. No? Yes, it's clear. Yes, it's not visible because of the slight spasm. Usually occur. Okay, no, not this way. Okay, let's take one fresh hybrid. Before I will check the spasm. Yes, everything is clear. Бақыт! 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 Мына жерде 8 бар. Ашып бересіз. Осы. Операционный ыстық болып тұр. Yes, it's quite hot in the operating room. Now we asked for another one, hybrid 8. Hybrid 8. Because we have no Chikai 8. Because of the stupid tender system and yes. Yes, everything is okay in Kazakhstan. Maybe some of the pathologies we shouldn't treat and the system tries to say about it. And we are quite stupid and do not understand what the system is trying to say. I think it's everywhere like this. And the system is okay, it's affording treatment for all citizens. The question of quality is subjective, yeah? Yes, it's very subjective. Because I want to do it like this. It's my fault, it's my mistake. Okay, it's okay. Everything is okay. Everything is okay. Everything is okay. Tomorrow will be tomorrow. I hope so. Even if we are not in this hospital, tomorrow will be tomorrow. Huh? Okay, then it's not going to the branch. Let's need more angulation, but if you do more angulation, then it's damaging. Okay. Now we need more angulation. If you do more angulation, then we damage the wire. That's a problem. Huh? Okay, it's a problem of the physician. Nowadays the clipping is the most trend because the hospital's earning approximately $8,000 for the clipping, and usual expense for the clipping is approximately $2,000, and hospital may earn $6,000, but it will not like this forever, because the insurance system gives support till the method. In the case of clipping, the method of clipping will be spread all around Kazakhstan, and it will be the approximately 50% of MCA aneurysms could be clipped, and that's it. And with the clipping, they destroy the endovascular approach. They want to show that the microsurgery is best, and okay, for the MCA maybe, but the MCA aneurysm is only 25% of all brain aneurysms. Yes, and it's a wrong way to do the management. Yes, I call it the management because I'm also the manager. I was a vice chairman of the big hospital, and I know what I'm saying. Yes. That's why they're also trying to bypass all coronary arteries, but then they killed the endovascular approach in a coronary atherosclerosis when the patient needs more than two coronary stents, and then if the patient needs more than two coronary stents, it should be bypass. I'm not sure it's a correct way of doing the management of coronary arteries, because in Uzbekistan, where the cardiac surgery is not the most trend, the main approach is endovascular, and the colleagues are doing more and more chronic occlusion interventions, as they have devices for the calcified plaque shockwave technology, which is not so much available in Kazakhstan because it's still not covered by the insurance system. When the shockwave will come to the country, then the most part of calcified plaques will become endovascularly treatable. Yes, it's so sad, huh? It's so sad because not all the patients could receive the coronary bypass. Okay, now we are in the branch, but the problem, we have a Sonic 1.5, which is a little bit stiffer than the other Sonics. The Sonic 1.2, and it's not going forward. So we should go a little bit. Yes, it's stuck at one of the branches. Okay, now we are going down. This voltage. Yes. And this community is saying about the gender equality, that the man and woman should be equal, and then they're trying to provide the microsurgery instead of the endovascular treatment. I don't understand, really. It's not about equality. Sorry, gender equality. Why not the treatment equality? Huh? Okay. Okay, let's wait. Maybe we can put a little bit nimodipine. There are a little bit bifurcation, and the catheter might stuck at the orifice of the branch. I couldn't push it as much as possible. I'm trying to do my best without harming the patient. Okay, now it's look like this. And it's protruding to the left. It's impossible to push. I don't know why. Yes, the 1.2 Sonic was the last, and we put it in the. Opa. Okay. Okay, let's wait. Maybe we can ask Bachat to give an editing in the flashing system. Немато пересанш бахтана промывка 15 саласанс. Екіншісіне саласанс, сосын ауыстыра саламыз. Okay, it's okay. There is no bleeding, it's okay. Let's start from the Pica microcatheter, which looks like this. Okay. The risk of rupture of the feeder in this territory is very high. That's why we will do very gentle injection, and we'll try to take as much as possible without penetrating the draining vein. Okay. И бізге squid пересанс 12. Squid also. 16. Yes, unfortunately, the squid 12 is finished. That's why we should work with this. Наркоз поглубже, dexamethasone 12. I asked for deeper narcosis and the dexamethasone 12 milligram because the DMSO is very painful. Excellent. Барбады? Okay. Okay, let's wait for the dexamethasone. Okay, no stress. Шашажик күйін болдырғы, не? Ашылды ма? Мынанда ашып жасашы. Зажим керек о? Ашылды ма? Зажим бересіңіз? Ашылды. Yes, it's quite tight. Все, у них рахмет. Ашыр. Берсін. Ашылды? Берсін. Сымке берсін. Жүрсін. Okay. Yes, Dravan is not married, that's why he has a lot of energy. He didn't spend this energy in the family, that's why. Okay. It was Bachat, no? Okay. Someone of them is not using the energy at home. That's why it's tight connection. Blue. Okay. Bismillahirrahmanirrahim. Okay, we start to inject, and I will ask Rowan to keep the eyes on reflux, because it's very important to avoid the refluxing, and as much as possible we should I think this is collateral, it's going from Pica. Okay. Yes, it's a connection, huh? It's not the vein, it's maybe it's a vein, huh? It's going down. Oh, it's artery. Rodno? Yes, we couldn't wait too much. Now we're refluxing. I think this reflux is enough. We don't need to do more. 10:09. It's 11:09. 11:10. We start refluxing. From this period of time, we should wait till the detachment of the microcatheter for 30 minutes, 25 minutes at least. It's a recommendation from Shimon Maimon. Okay, that's refluxing. That's reflux. Okay. I need to see the. Okay. Okay, now we can see the marker. Rodno? It's refluxing. Also going forward and a little bit backward. Yes, it's going backward. It's not going forward. Crossing. Okay, that's not going. Sometimes it's a sign that maybe not a good idea to go there. Huh? It's some signal. Okay, let's take out the wire. It's not going. Okay. Maybe we'll do на emodipine from here. 20-ка ек миллилитр немота принесешь? Ек миллилитр. Вперед. Okay. I'm not sure we should occlude all this segment because it might be the feeders for the cerebellum itself. That's why. Okay. Now we're injecting, and there is also the reflux. Okay, that's reflux. Okay, let's change the syringe for DMSO. Надеемся, не слышишь? дем суженесі. И маған мен бере сал. Okay, now we have a Mynzhylky. I will take this is Mynzhylky. We will inject through the sonic. Yes, I need to put it here. Okay, 1.5. Now we'll change the syringe. Стоит раз, а? Okay. Вот даем сон, окей. Смог мозг? Тоже. Родно. This looks like the branch for the cerebellum, huh? Okay. It's not bad. We injected diluted from 2 cc of Mynzhylky till 20, 3 cc. I think there is a spasm, huh? That's why it's not like this. Може че шпътът ми завтра на наверност. Yes, there is a spasm in the branch we were before. And the distal part is mostly going to the hemisphere, and the a little bit proximal one is going to the vermis. It's too distal, huh? It's too distal. Okay, let's see. Так, смарт мозг. Родно. Yes, I think we don't need to go to this SC branch. Maybe we'll do control. Okay, it's reflux till the second marker. Okay, I will take this time and we'll do the expert CT. It's time to do this expert CT. I like the gravity system. I can correct my glasses. Kaj tam fieso? Ai nu trebuie. Пока ai nu trebuie. Will exclude the bleeding, and then might be I will place we will place the sonic, the second sonic. Ана трубканы жылып кетет қазір. Наркозниктің трубкасын сәл артқа тарту керек. Есть ташаешь. Все отлично. Большое рисовался. Okay, let's do the expert CT. Рома.
Что с трубкой?
Рома. Okay, the expert CT is ready. Okay, let's check. This is the sonic. There is no bleeding, that's why we can move from this part. I'm not sure we should try to occlude all this part. Yes, it's mostly the cerebellum. But it's a little bit far from the brainstem. Yes, it's the cerebellum mostly. Okay. Проверни. Последний проекцион. Космочуш. Джовар жан бите салсын, қарай. Бите салсын. This projection is 89 caudal 15. Pardon? And all the time should keep in mind that the liquid embolic could be more proximal than you see on the fluoroscopy. It's a very important point. When you see the reflux, it might be 2-3 mm proximal than it's visible. Yes, now it's proximal. Bring my catheter back. Okay, it's detached. It's detached without problem. Мен алып қаласың. Кейін бір керек болып қалды. Просто столға қойсын. It looks like we created some spasm and might be thrombosis. That's okay. Okay, then we can see another branches, huh? Which is more. Okay. Now we can go there. It's more attractive. Smart mask. Okay, just a second. Navigate, smart mask. И гибрид тендер просто. Любой. The Pika territory is okay. Okay. We created a spasm and then we can see the other territory, which is very important. It's previously have been. Okay, let's see. I hope that angulation is not so tight. It's okay, it should work. Yes, I think we create some spasm, that's why we can see the other territory, and that part is also mostly going to the AVM. Okay, now we're inside the branch. This one, maybe the second one. Yes, this one. This one should be better. Okay. Maybe it's not the branch. Okay, let's see from here. Yes, I think the previous one we felt inside, it was the correct one. Now it's the same one. We should go to the more rostral one. Yes, now it's clear. But the both branch is creating the collaterals. Stop. Stop. Smart mask. Да. Maybe at the end of the treatment we will go to the middle meningeal artery and we'll occlude that feeder to go next time. Okay. To finalize the treatment today for the MMA and to leave the main feeder from the ICA. Yes, it should be this one. And this one. Yes, this one. Osaydı. Bonus. Stop. Осы сияқты ма? It's not like this one. Все, оно алдына барады да, бұрылады ғой. It's doing the U-turn. This direction, no? Yes, it's doing the U-turn. And coming here, yes. Okay. It's as much as possible. No? Okay, that's fine. Okay, now we can relax. Let's see, maybe we'll start with fill and then continue with the squid. Okay, nice one. Maybe squid is better, yes. Жаңағы squid қайтадан жинайсың. Yes, yes.
Мақсат 18.
It's a 1031. 1032. It's very important for the detachment. When we work with the EVOH, the time of injection is very important with the Sonic. With the Apollo it's not so important. И бағанағы демсоны дайындап қоясың, бері қарай алып келесің, грязный. И тағы да бір сквид жинап қоясыңшы. Окей. Yes, and then I will ask Rowan to keep the eyes on reflux. Okay, Rowan? It might be very close to the draining vein, no? Is it the draining vein territory? It might be. Very close. There is no stagnation, it's good. There are a lot of collaterals, that's why it might be a little bit confusing, but there is no reflux. Yes, it might be the previous branch, huh? Yes, it might be territory of previous branch. Alınlar yakın karısı. Yeah. Yes, it might be this branch. Then it goes down. This one goes this like this and then goes down. Okay. Smart mask. Araba. That's a collateral. Okay, let's wait a little bit. Timer razor. Timer. Yes, we are still working on the large focus because the small focus with the defect, and it was a question from the accountant department, economy department, why we destroyed the X-ray tube, why it's damaged. It's very bad. My wife Laura, she studied the economy in Baltic University in St. Petersburg, and it was a military mechanical university, and she should learn all the details in parallel with the studying the economy. It's a way to learn the economy in military mechanical. And I don't know why the economist in medicine not studying the medicine. Yes, they know the 1 + 1 will be 2, and that's it. It's very stupid, huh? They should be very confident in the medical procedures if they are judging the how much to spend in which patient. I think it's maybe kind of collateral occlusion. Okay, it's collateral occlusion. Yes, why they are not studying the medicine? Like a journalist, we had a discussion with the University of Al-Farabi about the preparation of the journalists in medicine. They should study medicine before starting to judge the physicians. There are also the, oh no, it looks like fenestration, but I hope it's not the fenestration. On AP it looks like some hole, something like fenestration. Okay. Rodno? Yes. I especially went to the MBA and I tried to study an economy to understand the way of thinking of the managers. And I'm really surprised why they are not studying the medicine. Huh? They're working in a hospital and they don't want to No. What they're counting, huh? I think it's everywhere like this. I think it's collateral. I'm not sure that it's a branch we're working. Okay. I think it was the second branch coming. Maybe a little bit pull the microcatheter to be sure that it's not glued. Yes, now we can see the proximal part. It's not inside the liquid embolic. Okay. It's a branch in parallel we were before. Yes, this branch. This one. Doing the curve. Now it's going inside the AVM. Huh? Yes, the bad point is we have no squid 12, which is more penetrable, and we should work only with the 18. Penetration ability of the squid 12 is more than... Okay. Yes, the main part of the AVM now occluded, and the remaining part is feeding mostly from the ICA. Okay. Slice covering is the AVM standard. Rodrigo Rivera from Chile, I think. He's from Chile. Or he's from... he's not from Colombia, he's from Latin America. I will check. Daniel was from Colombia, and this Rodrigo is maybe from Chile. I need to check. Yeah. It's extravasation, I think. Let's look like rupture near the tip of the microcatheter. Okay. It's time to stop. Then we will go to the external carotid. On the left side. Okay. Let's wait. Ясно. И даем оған, скорее всего, филмен жұмыс істей саламыз, көреміз. That's a maximum. That's a maximum. That's a maximum, yeah? Okay, let's leave it like this. little bit release. Okay, let's wait because we are working less than 15 minutes. Huh? Yes, everything is okay. It might be something coming from here. Huh? Okay. That's 1 million of images. Huh? Okay. We'll go here and we'll include this one. We use 2 Sonics in the department and another 2 is on the shelf. Huh? Daha da 2 oldu. It's 15 minutes from the start of injection, and now I will try to pull it one more time. Okay, it's вытащит. Қайтадан қойсын. Хотя түге саш, ол тоже бітті ғой деймін. Ішіндегі контраст тоже көрінбейді.
18 жинайын ба?
Пока динамотор отыр. Maybe we need to do one more city to control. Okay. It's on navigation. Вроде все на месте. Проводник. First of all, we will catheterize the external carotid artery on the left side. Then we will do intermediate expressity. Or we can include from the SC and from the external carotid. It's internal. It's external. Let's check it. Let's see. Yes, it's still there. Стоп, назад. Окей. Вперед. Стоп. Ага, осы. Соник бере салшы. Бағыт. Может, кіріп қоя салыңыз. Может, жібере салып, сосын жасайсыңыз. Соник. 1.5 21. Аша бер.
Не без нашения.
Жоқ, керегі жоқ. И fill'dı verirsin. Gibi taşısır. Fill taşısın. Екі шприц шығару үшін. This is a fresh one. Okay.
Шприц керек қой. Мало.
Держать это. Ножи хватит. Yes, the middle meningeal artery is a killer of hybrid, but I hope this hybrid will reach the point without dying before. We have another 3 hybrids from the previous microcatheters. Let's see. Let's see what we can do. Yes, for this anatomy, usually I prefer to use headway duo in combination with Traxxas 14, which is more reliable combination. But it's a new reality, like after COVID. We are living in new reality when the the instruments are not all the time available. It's a new reality. It's okay. It's life. It's part of life. Yes, as I said before, it's a killer of the hybrid. Huh? Опа. Алдында біреуін бересің. Но пока троюсь. Басқасын бересің. We'll try one of the previous one. It's just a dural fistula. The patient had a tinnitus And this is the reason of tinnitus. Huh? Okay. Stop. Okay. It's not feeding the AVM, that's why maybe it will be more comfortable to work with feel. It's not going. Let's take other one. Maybe this one. Okay. This one. Oh, it was thrown on the floor. On EP it looks like it will go. Yes, it's going. Okay. Okay. Which position? I hope it's quite far from the... Yes. Okay, let's... This part is not so dangerous, but because of the symptoms of tinnitus, I think this is the main cause of tinnitus. We can exclude it today, yeah? You should be very careful with the petrosal part. It's not so much visible. Okay, now it's going to the collaterals. You can do it like this. I think it's inside the sinus. Pull the guiding catheter till the occipital. You should check occipital territory also. This is all part of the fistula, maybe. Okay. That's the reflection. Okay. Читать. Ровно? Ровно? I think it's a problem with the small focus, why we don't see it. Okay, let's finish. I'm not sure that what to do now. No, traversing. Шприц мне подготовишься. Okay, it looks like it's occluded. Better. Okay. Now we need to check. Устная позвоночная вот, yes, it looks like carotid, but it's a vertebral. Yes, there was some venous stagnation. Good. Good. It's not inside the AVM, it's on the draining vein, дренажная вена. Okay. I hope in a couple of months we can do the next session. And it will be occluded. Okay. I think we occluded part of the pica. That's the stagnation in pica, but it feels from the collaterals. As you can see, yes, it was the feeder from pica to AVM and it's occluded, and now pica is feeding the distal part from collaterals and proximal part is just stopping at the liquid embolic. Okay, it's a possible scenario. Millions of branches, Хорошо, как это рисуешь? Okay, I asked Rowan to do expertise control to do the final decision. And the next case, patient had a little bit high level of creatinine. Now we should check. Пока звук можно. Okay, dear colleagues, the expertise looks like good. There is no complication concerning these images. Now we can finish and we'll check the second patient, and then if he will be okay in 30 minutes, next case. I hope so. Okay, see you.